The emergency room at St. Mary's Hospital erupted into chaos at 3:47 a.m. A multi-vehicle accident on Interstate 95 had just brought in 7 critical patients simultaneously. Doctors scrambled. Nurses ran between rooms. The air crackled with tension and the sharp beeping of monitors. Before we jump back in, tell us where you're tuning in from, and if this story touches you, make sure you're subscribed because tomorrow I've saved something extra special for you. In the middle of it all, Dr. Sarah Mitchell moved with an almost supernatural calm. While others shouted orders and fumbled with equipment, she glided between patients with perfect precision. Her hands never shook. Her voice never wavered. Every decision she made seemed to flow effortlessly from some invisible well of intuition. By dawn, all 7 patients were stable. The other doctors stood exhausted in the break room, shaking their heads in amazement. "How does she do it?" one resident whispered. "She's just lucky," another replied with a shrug. "Some people are born with it." But luck had nothing to do with it. What they couldn't see were the countless hours Sarah had spent preparing for moments exactly like this. What they dismissed as natural talent was actually the result of 20 years of relentless, methodical training that no one else even knew existed. Sarah Mitchell had been working the night shift at St. Mary's for 3 years. Not because she wanted to, but because that's where they put the doctors who didn't quite fit the mold. The administration had never said it directly, but the message was clear. The day shift was for the real stars, the ones who impressed the department heads and published papers. Night shift was for everyone else. She clocked in every evening at 6 p.m. sharp, her hospital badge swinging from a retractable cord clipped to her scrubs. The photo on the badge showed her with shorter hair and a more optimistic expression. 3 years of night shifts had changed both. Her brown hair now fell past her shoulders, usually pulled back in a practical ponytail. Her eyes, though still sharp and intelligent, carried the weight of someone who had seen too much and received too little recognition for it. The night shift staff was a collection of misfits and overlooked talent. There was Marcus, the charge nurse who had been passed over for promotion 4 times despite his exceptional skills. Rebecca, the respiratory therapist who spoke 3 languages, but was never asked to participate in the hospital's diversity initiatives. And Tom, the radiology technician whose innovative techniques had saved countless lives, but were never formally recognized, because they weren't standard protocol. Sarah fit right in. She was the doctor who consistently had the best patient outcomes, but was never invited to the monthly department meetings. Her success rates were quietly impressive, but she lacked the political connections that seemed to matter more than actual medical competence. While her day shift colleagues networked at medical conferences and published research papers, Sarah was treating actual patients, saving actual lives, and getting no credit for it. Dr. Harrison Webb, the department head, barely acknowledged her existence. During their rare interactions, he would nod politely and make vague comments about keeping up the good work on nights. But Sarah knew what he really thought. She had overheard him talking to Dr. Jennifer Cross, one of the rising stars of the day shift, during a chance encounter in the hospital cafeteria. "Mitchell? Oh, she's fine for nights," Webb had said, stirring sugar into his coffee. "Some people just have a knack for routine stuff. Lucky for us, really. Not everyone can handle the complex cases we get during the day." Dr. Cross had laughed, a sound that made Sarah's stomach tighten. "I don't know how she does it, honestly. I'd be bored out of my mind with all those simple cases. Give me a real challenge any day." What they didn't understand was that Sarah's simple cases were anything but simple. The night shift at St. Mary's saw everything: overdoses, heart attacks, strokes, accidents, domestic violence, psychiatric emergencies, and trauma cases that would challenge any doctor. The difference was that night shift doctors had fewer resources, less support staff, and no backup from specialists. They had to be ready for anything, and they had to handle it mostly on their own. Sarah had learned to read situations with an almost preternatural accuracy. She could walk into a room and assess a patient's condition in seconds, not through magic or intuition, but through years of recognizing patterns that others missed. The way a patient's skin looked under fluorescent lights, the sound of their breathing, the position they held their body in, the smell of their breath. 1,000 tiny details that painted a complete picture for anyone who knew how to look. But to her colleagues, it looked like luck. When Sarah correctly diagnosed a rare condition that 3 other doctors had missed, it was luck. When she successfully treated a patient who had been written off as hopeless, it was luck. When she prevented a medical emergency from becoming a disaster, it was luck. Dr. Amanda Foster, a second-year resident who rotated through night shifts, had worked with Sarah for 2 months. Amanda was brilliant, ambitious, and destined for great things in the medical field. She had graduated at the top of her class from Johns Hopkins and was already being courted by prestigious residency programs. But working with Sarah had been a humbling experience. "I don't get it," Amanda confided to her friend during a phone call one evening. "Dr. Mitchell just knows things. Like, we'll get a patient with chest pain, and I'm running through the differential diagnosis, ordering tests, following protocol. But she'll take one look at the guy and say, 'Get me a chest x-ray and start him on antibiotics,' and she's always right. It's like she has some kind of sixth sense." Amanda's friend, another resident at a different hospital, had laughed. "Some people are just naturally gifted. My attending says some doctors are born with it, others have to work for it. Sounds like you're working with one of the lucky ones." But luck wasn't what guided Sarah's decisions. It was an experience. It was pattern recognition. It was the result of treating thousands of patients and remembering every single case. Sarah had developed what she privately called her mental database, a vast catalog of symptoms, presentations, and outcomes that she could access instantly. When she looked at a patient, she wasn't seeing them in isolation. She was seeing them in the context of every similar case she had ever encountered. Take the chest pain example that had impressed Amanda. Sarah had seen that exact combination of symptoms 43 times in her career. 38 of those cases had been pneumonia presenting atypically. 3 had been pulmonary embolisms. 2 had been anxiety attacks. Based on the patient's age, gender, posture, skin color, and breathing pattern, Sarah could determine which category this patient fell into with 95% accuracy. To Amanda, it looked like magic. To Sarah, it was simply applied experience. The night shift at St. Mary's had its own rhythm and culture. The cafeteria served different food, heartier, more practical meals for people who worked while the rest of the world slept. The hallways echoed differently at night, footsteps and voices carrying further in the relative quiet. The lighting was dimmer, more atmospheric. Even the air felt different, charged with the intensity of people working at the edge of human endurance. Sarah had found her place in this world. She knew every nurse by name, every technician's strengths and weaknesses, every quirk of the hospital's nighttime operations. She knew which vending machine had the best coffee, which elevator was fastest, which supply closet always had what she needed. She knew the security guards' patrol routes and the cleaning staff schedules. She knew which rooms had the best cell phone reception and which ones had temperamental equipment. This knowledge made her incredibly effective, but it also made her invisible. The day shift administrators never saw her seamless integration with the night staff. They never witnessed the way she could coordinate complex procedures with a nod and a glance. They never observed how she had optimized her workflow to handle 3 times the patient load of a typical day shift doctor. Dr. Michael Chun, the night shift's unofficial leader, had been watching Sarah for 2 years. Chun was a veteran emergency physician who had chosen nights by preference, not circumstance. He appreciated the autonomy and the absence of hospital politics. He had seen many doctors come and go, but Sarah was different. She had the technical skills, the emotional intelligence, and the work ethic to be truly exceptional. But more than that, she had something rare, the ability to remain calm and focused under extreme pressure. "She's wasted her nights," Chun had told Marcus during a quiet moment in the break room. "Not that I don't appreciate having her here, but she could be running her own department somewhere." "She's got the skills," Marcus had nodded thoughtfully. "So why isn't she? Politics?" "Partly," Chun had replied. "But also, I think she's preparing for something. Have you noticed how she handles the really difficult cases? It's not just competence. It's like she's been training for something specific." Chun was more perceptive than most. He had noticed that Sarah approached certain types of cases with an intensity that went beyond normal professional dedication. Trauma cases especially, multi-victim accidents, complex medical emergencies that required split-second decisions and perfect coordination. She didn't just treat these patients. She studied them, learned from them, incorporated every lesson into her ever-expanding knowledge base. The truth was that Sarah had been preparing for something specific. She had been preparing for the moment when her skills would be truly tested, when the difference between competence and excellence would matter more than hospital politics or administrative approval. She had been preparing for the moment when lives would depend not on luck, but on the kind of deep, comprehensive expertise that could only be built through years of dedicated practice. But until that moment came, she remained invisible. The night shift doctor who got results through some mysterious combination of intuition and good fortune. The one who was just lucky to be in the right place at the right time, with the right instincts to handle whatever came through the emergency room doors. What they couldn't see was the methodical nature of her preparation. The way she reviewed every case, successful or not, looking for patterns and lessons. The medical journals she read during her breaks, not for career advancement, but for pure knowledge. The continuing education courses she took on her own time, paying for them out of her own pocket. The simulation exercises she practiced in her head during quiet moments, running through emergency scenarios and refining her responses. Sarah Mitchell wasn't lucky. She was ready. And eventually, the world would learn the difference. What Sarah's colleagues didn't know was that her apartment had been transformed into a medical training facility. The spare bedroom that should have held exercise equipment or a desk instead housed a sophisticated mannequin designed for advanced cardiac life support training. The dining room table was permanently covered with medical textbooks, research papers, and hand-drawn diagrams of anatomical structures. Her living room coffee table held 3 different stethoscopes, a blood pressure cuff, and a collection of medical instruments that she practiced with during her off hours. Preparing and narrating this story took us a lot of time, so if you are enjoying it, subscribe to our channel. It means a lot to us. Now back to the story. Every surface in Sarah's apartment told the story of obsessive preparation. The kitchen refrigerator was covered with laminated cards containing drug dosages, emergency protocols, and quick reference guides she had created herself. The bathroom mirror had medical mnemonics taped around its edges, memory aids for remembering the signs of stroke, the symptoms of heart attack, the steps of trauma assessment. Even her bedroom nightstand held a collection of medical journals with bookmarks and highlighted passages. This wasn't the home of someone who relied on luck. This was the residence of someone who had dedicated every spare moment to becoming the most prepared doctor possible. Sarah had spent the last 2 decades building a fortress of knowledge, and she had done it entirely on her own time, with her own money, driven by her own relentless standards. The transformation had begun during her residency at Massachusetts General Hospital. Sarah had been a good student in medical school, but not exceptional. She graduated in the middle of her class with solid grades and respectable recommendations. But during her first week of residency, she had witnessed something that changed her approach to medicine forever. Dr. Elizabeth Hartwell, the chief of emergency medicine, had been faced with a patient who arrived unconscious after a construction accident. The patient's vital signs were unstable, his breathing was labored, and he was bleeding from multiple wounds. 2 residents had already examined him and were debating whether to order a CT scan or stabilize him first. Meanwhile, the patient's condition was deteriorating. RAPIDLY Dr. Hartwell had taken one look at the patient and immediately began a series of interventions that seemed to come from nowhere. She repositioned his airway, applied pressure to a wound that the other doctors had missed, and ordered a specific combination of medications that wasn't in any textbook Sarah had ever read. Within minutes, the patient was stable. Within an hour, he was conscious and talking to his family. "How did you know to do that?" Sarah had asked Dr. Hartwell later that day. Dr. Hartwell had paused, considering her answer carefully. "I've seen this exact scenario 47 times in my career," she said finally. "Each time, I learned something new. Each time, I got a little bit better. The difference between a good doctor and a great doctor isn't talent, Sarah, it's preparation. It's seeing every case as a learning opportunity and never stopping the process of improvement." That conversation had planted a seed that would grow into Sarah's lifelong obsession with preparation. She began keeping detailed notes on every patient she treated, not just for legal purposes but for her own education. She started a filing system that cataloged symptoms, treatments, and outcomes. She began treating every case as a puzzle to be solved and learned from. But the real transformation had come 5 years later, during her fellowship at Johns Hopkins. Sarah had been working with Dr. Robert Kim, a trauma surgeon who was known for his ability to save patients that other doctors had given up on. Dr. Kim had a reputation for being incredibly lucky. He always seemed to make the right decision at the right moment, always seemed to know exactly what to do in impossible situations. One evening, Sarah had stayed late to finish paperwork and had noticed Dr. Kim's office light was still on. She had knocked on his door to ask a question about a patient and had discovered him surrounded by medical textbooks, research papers, and a large whiteboard covered with diagrams and notes. He was studying a case from 3 months earlier, breaking down every decision he had made, analyzing alternative treatments, and researching newer techniques that might have been more effective. "Dr. Kim?" Sarah had said, surprised. "What are you doing?" He had looked up from his notes, slightly embarrassed. "Oh, Sarah, I didn't realize anyone was still here. I'm just reviewing some cases, trying to figure out how I could have done better." Sarah had looked around the office, taking in the evidence of intense preparation. "But that patient did fine. You saved his life." "That's not the point," Dr. Kim had replied. "The point is that I could have saved his life more efficiently, with less risk, using better techniques. Every case is a learning opportunity. Every success is a chance to identify areas for improvement." That night, Sarah had gone home and completely reorganized her approach to medical practice. She had started what she called her preparation protocol, a systematic method of continuous improvement that would guide her for the next 15 years. The protocol had several components. First, she would review every case she handled, writing detailed notes about what had worked, what hadn't, and what she would do differently next time. Second, she would research any condition or technique she encountered that was new to her, creating comprehensive reference materials that she could access quickly. Third, she would practice procedures and scenarios in her spare time, using whatever equipment she could afford to buy or borrow. But the most important component was what she called pattern recognition training. Sarah had realized that experienced doctors weren't just lucky, they were able to recognize patterns that younger doctors missed. They had seen enough cases to know what certain combinations of symptoms meant, what certain patient presentations indicated, what certain changes in vital signs predicted. So Sarah had begun systematically studying patterns. She would spend hours reviewing case studies, looking for commonalities and differences. She would create flowcharts and decision trees that helped her remember the subtle signs that distinguished one condition from another. She would quiz herself on rare conditions and unusual presentations until she could recognize them instantly. The mannequin in her spare bedroom was the centerpiece of her practical training. Sarah had purchased it from a medical supply company, paying for it with 3 months' worth of savings. It was designed to simulate cardiac arrest, respiratory failure, and various emergency scenarios. Sarah would practice on it for hours, running through different emergency protocols until her responses became automatic. She had also created her own simulation scenarios. Using her research and case notes, she would imagine complex medical emergencies and practice her response. She would set timers to create pressure, force herself to make decisions quickly, and then analyze her performance afterward. She would identify mistakes, research better approaches, and practice until she could handle any scenario flawlessly. The medical journals scattered throughout her apartment weren't just for keeping up with current research. Sarah had subscribed to every major medical publication, and she read them systematically. She would highlight important findings, create summaries of new techniques, and integrate the latest research into her practice. She had filled dozens of notebooks with her own observations and insights. But perhaps most importantly, Sarah had developed what she called her mental library, a vast collection of case studies, treatment protocols, and medical knowledge that she could access instantly. She had memorized thousands of drug interactions, hundreds of emergency procedures, and dozens of rare conditions. She had studied the symptoms of diseases that most doctors would never encounter in their entire careers. This preparation wasn't driven by ambition or career advancement. Sarah wasn't trying to impress anyone or get promoted. She was driven by a simple belief that every patient deserved the best possible care, and that the only way to provide that care was to be prepared for anything. The irony was that her preparation made her appear less prepared to her colleagues. Because she could diagnose conditions quickly and treat patients efficiently, they assumed she was just naturally gifted. They didn't see the hours of study, the constant practice, the relentless self-improvement that made her quick decisions possible. Dr. Amanda Foster, the resident who had worked with Sarah, had once tried to compliment her on her natural abilities. "You're so lucky to have such good instincts," Amanda had said. "I have to think through everything step by step. You just know what to do." Sarah had smiled politely, but inside she had felt frustrated. There was nothing natural about her abilities. Every instinct was the result of careful study and practice. Every quick decision was based on years of accumulated knowledge and experience. What Amanda saw as luck was actually the opposite. It was the result of eliminating luck from the equation entirely. Sarah had learned to rely on preparation rather than intuition, on knowledge rather than guesswork, on systematic thinking rather than spontaneous inspiration. She had spent 2 decades building the skills and knowledge that would allow her to handle any medical emergency with confidence and competence, but she had also learned not to explain this to her colleagues. They seemed more comfortable believing that her abilities were the result of natural talent or good fortune. It was easier for them to accept that some people were just luckier than others than to acknowledge the level of preparation that true expertise required. So Sarah had kept her preparation secret. She had let her colleagues believe what they wanted to believe while she continued to build her fortress of knowledge. She had worked quietly, studying constantly, practicing relentlessly, preparing for the day when her skills would be truly tested. That day was coming sooner than she knew. The annual St. Mary's Hospital Excellence Awards ceremony took place in the grand ballroom of the downtown Marriott. The room buzzed with conversations between doctors in formal attire, administrators in expensive suits, and board members who rarely set foot in the actual hospital. Crystal chandeliers cast warm light over round tables decorated with white linens and centerpieces that probably cost more than most nurses made in a week. Sarah sat at table 12, tucked away in the back corner with the other night shift staff. She wore a simple black dress that she had owned for 5 years, her hair pulled back in the same practical style she wore to work. Around her sat Marcus, Rebecca, Tom, and a handful of other night shift employees who had been invited more out of obligation than genuine recognition. At the front of the room, Dr. Harrison Webb stood behind a podium, reading from a prepared script about the hospital's achievements over the past year. His voice carried the practiced cadence of someone who had given this speech many times before, with slight variations for different audiences and occasions. "This year has been particularly remarkable," Webb announced, his voice amplified by the sound system. "Our day shift emergency department has achieved a 97% patient satisfaction rating, a 15% reduction in average treatment time, and recognition from the State Medical Board for innovative treatment protocols." Applause filled the room. Sarah clapped politely, but her mind was elsewhere. She was thinking about the patient satisfaction surveys that never reached night shift patients, the treatment time statistics that didn't include the complex cases that came in after midnight, and the innovative protocols that had actually been developed by night shift doctors but were never officially documented. The awards ceremony continued with a parade of recognition for day shift accomplishments. Dr. Jennifer Cross received the Outstanding Physician of the Year award for her work on a cardiac catheterization program that had improved heart attack survival rates by 8%. Dr. Michael Bradley was honored for his research on emergency psychiatric interventions that had reduced involuntary commitment rates by 12%. Dr. Susan Walsh was praised for developing a new triage system that had streamlined patient flow during peak hours. Each award was met with enthusiastic applause and congratulatory remarks from Webb about the recipient's dedication, innovation, and commitment to excellence. Each winner gave a brief speech thanking their colleagues, their mentors, and the hospital administration for their support. What the audience didn't know was that Sarah had been quietly achieving similar results on the night shift for years. Her patient satisfaction scores, when they were actually measured, consistently exceeded 98%. Her treatment times were 23% faster than the hospital average. Her diagnostic accuracy rate was 96.7%, higher than any other emergency physician in the hospital's history. But these achievements were invisible to the administration. Night shift statistics weren't included in the hospital's annual reports. Night shift innovations weren't documented in official protocols. Night shift successes weren't celebrated at awards ceremonies. Sarah had learned this lesson the hard way 2 years earlier. She had developed a new approach to treating drug overdoses that had reduced mortality rates by 30% and decreased average hospital stay by 2 days. The technique involved a specific combination of medications and monitoring protocols that she had perfected through months of careful observation and adjustment. When she had submitted her findings to the hospital's medical review board, she had been told that the data was insufficient and that her sample size was too small to draw meaningful conclusions. Dr. Webb had politely suggested that she continue to gather data and perhaps collaborate with one of the day shift physicians who had more experience with research protocols. 6 months later, Dr. Cross had published a paper on the exact same technique in the Journal of Emergency Medicine. The paper credited her with developing the protocol and made no mention of Sarah's prior work. When Sarah had questioned this, she was told that Dr. Cross had independently arrived at similar conclusions, and that there was no evidence of prior development of the technique. Sarah had learned to document everything after that incident. She kept detailed records of every innovation, every improvement, every successful outcome. She photographed her notes, saved her research, and created a comprehensive database of her contributions to emergency medicine. But she had also learned that documentation wasn't enough. Without the right connections, without the right political support, without the right visibility, her work would continue to be overlooked. The disconnect between Sarah's actual contributions and her official recognition had become a source of constant frustration. Every month, she would see day shift physicians receive praise for techniques she had developed, recognition for outcomes she had achieved, and opportunities she had never been offered. Dr. Amanda Foster, the resident who had rotated through night shifts, had been a perfect example of this disconnect. Amanda had worked with Sarah for 2 months, during which time Sarah had taught her advanced diagnostic techniques, shared her insights about patient care, and mentored her through dozens of complex cases. At the end of her rotation, Amanda had been effusive in her praise. "Dr. Mitchell, you're incredible," she had said. "I've learned more from you in 2 months than I learned in my entire previous year of residency. You have this amazing ability to see things that other doctors miss." But when Amanda had presented her rotation report to the residency program director, she had focused on the valuable learning experiences and diverse caseload of the night shift, without mentioning Sarah's specific contributions. When she had been asked about her mentors during the rotation, she had mentioned Dr. Chun, the night shift supervisor, but had described Sarah as a really experienced physician who seems to have great instincts. Sarah had read Amanda's evaluation report and had felt a familiar sting of disappointment. 2 months of intensive mentoring, dozens of hours of teaching, and countless shared insights had been reduced to a vague comment about great instincts. The pattern repeated itself constantly. Medical students would rotate through night shifts, learn from Sarah's expertise, and then describe her contributions in terms of natural ability rather than learned skill. Residents would observe her diagnostic techniques, benefit from her guidance, and then credit their improvement to their own developing clinical judgment. Even her colleagues on the night shift sometimes fell into this pattern. Dr. Chun, despite his respect for Sarah's abilities, would occasionally refer to her as naturally gifted when discussing her performance with other staff members. Marcus, the charge nurse, would tell new employees that Sarah was just one of those doctors who has the touch. These comments were well-intentioned, but they perpetuated the myth that Sarah's abilities were the result of luck or natural talent, rather than systematic preparation and continuous learning. They made her achievements seem effortless, which diminished their value and made them seem less worthy of recognition. The disconnect was perhaps most frustrating during medical conferences and professional development events. Sarah rarely attended these gatherings, partly because of her night shift schedule, but mostly because she had learned that her presence was neither expected nor particularly welcome. When she did attend, she would often find herself listening to presentations about techniques she had developed, approaches she had pioneered, and outcomes she had achieved. The presenters would be day shift physicians who had adapted her methods, built upon her research, or simply claimed credit for her innovations. At one particularly memorable conference, Sarah had attended a presentation by Dr. Bradley on emergency psychiatric interventions. The technique he was describing was nearly identical to an approach Sarah had developed 3 years earlier for handling agitated patients during night shifts. She had documented the method, tracked its effectiveness, and shared it with several colleagues. During the question and answer period, Sarah had stood up and asked about the historical development of the technique. Dr. Bradley had looked uncomfortable for a moment, then had given a vague response about building on established best practices and collaborating with colleagues throughout the hospital. After the presentation, Sarah had approached Dr. Bradley privately. "That technique you presented," she had said carefully, "I've been using a very similar approach for several years." Dr. Bradley had smiled condescendingly. "Well, you know how it is in medicine," he had replied. "Great minds think alike. Sometimes multiple people develop similar approaches independently. It's one of the wonderful things about our profession." Sarah had left the conference early that day, frustrated by the casual dismissal of her contributions and the comfortable assumption that her work was simply a coincidence. The growing disconnect between her actual abilities and her perceived Value had begun to affect her relationships with colleagues. She had become more guarded in her interactions, less willing to share her insights, and more protective of her innovations. She had learned to be cautious about what she disclosed and to whom she disclosed it. This caution had been misinterpreted by some as aloofness or arrogance. Dr. Webb had once commented to another administrator that Sarah was competent, but not particularly collaborative. Dr. Cross had described her as skilled but not really a team player. These characterizations had followed Sarah through performance reviews and career development discussions, creating a reputation that was completely at odds with her actual behavior and contributions. The irony was that Sarah was actually more collaborative than most of her colleagues. She had mentored dozens of residents, taught countless medical students, and shared her knowledge freely with anyone who showed genuine interest in learning. But her collaboration was invisible because it happened at night, away from the administrators and department heads who made decisions about recognition and advancement. Sarah had gradually realized that the disconnect wasn't accidental. It was systemic. The hospital's culture valued visibility over competence, networking over skill, and political savvy over patient outcomes. The physicians who succeeded were those who understood how to work within this system, not necessarily those who were best at practicing medicine. This realization had been both liberating and frustrating. Liberating because it explained why her efforts to gain recognition through traditional channels had been unsuccessful. Frustrating because it meant that her path to advancement would have to be entirely different from what she had expected. But Sarah had also begun to understand that recognition from the hospital administration wasn't the only form of validation that mattered. Her patients knew the difference between competent care and exceptional care. Her colleagues on the night shift understood the value of her contributions. The residents and students she had mentored carried her lessons into their own practices. Most importantly, Sarah had begun to realize that her preparation wasn't just about gaining recognition. It was about being ready for the moment when her skills would be truly tested, when the difference between good medicine and great medicine would be measured in lives saved rather than awards received. That moment was approaching faster than anyone realized. The text message arrived at 2:47 a.m. on a Tuesday morning in March. Sarah was in the middle of suturing a laceration on a construction worker's forearm when her phone buzzed against her hip. She ignored it initially, focusing on the delicate work of closing the wound with precise, even stitches. The worker, a middle-aged man named Carlos, had been injured when a piece of machinery malfunctioned at a downtown construction site. Almost done, Sarah murmured, her hand steady despite the fluorescent lights that cast harsh shadows across the examination room. Carlos nodded, his face pale but determined. He had been stoic throughout the procedure, asking only whether he would be able to return to work next week. Sarah tied off the final stitch and applied a clean bandage. "Keep it dry for 48 hours, she instructed, handing Carlos a care sheet. "Come back in 10 days to have the sutures removed. Any signs of infection, increased redness, warmth, pus, or red streaking, come back immediately." As Carlos left, Sarah finally glanced at her phone. The message was from Dr. Patricia Reynolds, the hospital's chief of staff. It was brief and urgent. "Emergency staff meeting, conference room and now." Sarah frowned. Emergency staff meetings at 3 a.m. were virtually unheard of. She made her way quickly through the hospital corridors, her footsteps echoing in the relative quiet of the night shift. The conference room was located on the second floor, adjacent to the administrative offices that were typically empty at this hour. When she arrived, she found the room buzzing with activity. Dr. Reynolds stood at the front, her usually immaculate appearance slightly disheveled. Her gray hair was pulled back hastily, and her clothes suggested she had been called in from home. Around the room, Sarah recognized faces from various departments, not just emergency medicine, but surgery, internal medicine, pediatrics, and critical care. Dr. Webb was there, looking confused and slightly annoyed at having been summoned from his bed. Dr. Cross sat near the front, her notebook open and pen ready, already positioning herself as someone who would be essential to whatever was about to unfold. Dr. Chun had arrived just before Sarah, and he caught her eye with a questioning look. "Thank you all for coming on such short notice," Dr. Reynolds began, her voice carrying the weight of someone about to deliver difficult news. "I've called this meeting because we're facing an unprecedented situation. At 2:15 a.m. we received notification from the Department of Homeland Security that a potential terrorist incident is unfolding in our city." The room fell silent. Sarah felt her stomach tighten, but her expression remained calm. She had prepared for this possibility, had run scenarios in her mind, had studied the protocols and procedures that would be required in a mass casualty event. A chemical plant explosion occurred at the Riverside Industrial Complex, Dr. Reynolds continued. "Initial reports suggest that a storage tank containing chlorine gas has been breached. The explosion has caused significant structural damage to surrounding buildings, and there are concerns about toxic gas exposure affecting a large number of civilians." Dr. Webb raised his hand. "What's our expected patient load?" "That's the problem," Dr. Reynolds replied. "We don't know. Early estimates suggest anywhere from 50 to 300 casualties, with varying degrees of trauma and chemical exposure. The incident is still developing, and first responders are having difficulty accessing the scene due to the gas cloud." Sarah's mind was already working through the implications. Chlorine gas exposure would cause respiratory distress, chemical burns to the eyes and skin, and potentially fatal pulmonary edema. Combined with trauma injuries from the explosion and building collapses, they were looking at a complex mass casualty event that would test every aspect of the hospital's emergency response capabilities. "We're implementing the hospital's disaster response protocol effective immediately," Dr. Reynolds announced. "Dr. Webb, I need you to coordinate with the day shift physicians who are being called in. Dr. Cross, you'll be in charge of triage protocols. Dr. Bradley, you'll handle psychiatric crisis intervention for survivors and families." Sarah waited for her name to be called, for her assignment in this critical situation. She had more experience with chemical exposure cases than anyone in the room, having treated dozens of industrial accident victims during her night shifts. She had studied mass casualty protocols extensively, had run through scenarios in her head countless times, but Dr. Reynolds continued assigning roles without mentioning Sarah's name. Dr. Johnson would coordinate with surgery. Dr. Martinez would handle pediatric cases. Dr. Thompson would manage the intensive care unit overflow. One by one, the day shift physicians were given crucial responsibilities in the response effort. Finally, Dr. Reynolds turned to the night shift staff. "Dr. Chun, you'll continue managing the regular emergency department operations. We can't afford to shut down normal services entirely. Dr. Mitchell, you'll assist Dr. Chun with routine cases and help wherever needed." Sarah felt a familiar sting of disappointment, but she kept her expression neutral. Help wherever needed was code for handle the less important cases while the real doctors managed the crisis. She had been relegated to a supporting role in the exact type of emergency she had been preparing for her entire career. As the meeting broke up, physicians scattered to their assigned positions. Sarah approached Dr. Reynolds, who was gathering her papers and preparing to leave. "Dr. Reynolds," Sarah said quietly, "I have extensive experience with chemical exposure cases. I've treated more chlorine gas victims than anyone in this hospital. I'd like to be more directly involved in the response." Dr. Reynolds paused, looking slightly impatient. "I appreciate your willingness to help, Dr. Mitchell, but we need our most experienced physicians handling the complex cases. Dr. Cross has been working on mass casualty protocols for months. Dr. Bradley has specialized training in disaster response. We need to put our best people in the most critical positions." The dismissal was polite but firm. Sarah nodded and left the conference room, her jaw tight with frustration. She had been preparing for this exact scenario for years, but her preparation was invisible to the administration. They saw her as a competent night shift doctor, not as someone who could handle the hospital's most challenging cases. As she walked back to the emergency department, Sarah's phone began buzzing with news alerts. The local news stations were reporting on the explosion, showing aerial footage of the industrial complex engulfed in a green-tinged cloud. The evacuation zone had been expanded to include residential areas within a 2-mile radius. Emergency. Responders were setting up decontamination stations and triage areas. The first patients began arriving at 3:45 a.m. They came in ambulances, police cars, and private vehicles. Some walked in on their own, coughing and wheezing, their eyes red and streaming. Others were carried on stretchers, unconscious or semi-conscious. Their breathing labored and shallow. Sarah watched from the sidelines as Dr. Cross took charge of the triage area. Cross was competent, but she was clearly overwhelmed by the complexity of the situation. She was relying heavily on standard protocols, following textbook procedures that didn't account for the unique combination of trauma and chemical exposure they were seeing. One patient, a young woman in her 20s, was classified as moderate priority by the triage team. But Sarah could see from across the room that the woman's breathing pattern indicated severe respiratory distress. The slight blue tinge around her lips suggested cyanosis, and the way she was positioning her body indicated that her condition was deteriorating rapidly. Sarah approached the triage desk. "That patient in bed 3, she said to the nurse. "She needs immediate intervention. Her respiratory status is declining." The nurse looked confused. Dr. Cross classified her as moderate. "She's scheduled for evaluation in 20 minutes. "She won't last 20 minutes, Sarah said firmly. "She needs intubation and mechanical ventilation now." Dr. Cross, overhearing the conversation, hurried over. "Dr. Mitchell, I appreciate your concern, but I've assessed this patient according to standard triage protocols. She's stable for now." Sarah looked at the patient again. The woman's breathing had become even more labored in the past few minutes. Her oxygen saturation, displayed on the bedside monitor, was dropping steadily. "Dr. Cross, with respect, this patient is showing signs of acute respiratory distress syndrome. The chlorine gas exposure has caused severe lung inflammation. She needs immediate intervention." Dr. Cross's expression hardened. "I've been working on mass casualty protocols for months, Dr. Mitchell. I think I'm qualified to make triage decisions." Before Sarah could respond, the patient's oxygen saturation dropped to 82%. The monitor began alarming, its urgent beeping filling the already chaotic emergency department. The patient's breathing became even more labored, and she began showing signs of panic as she struggled to get enough air. "She's crashing," Sarah said, moving toward the patient. But Dr. Cross blocked her path. "I'll handle this," Cross said firmly. "You're assigned to routine cases." Sarah watched in frustration as Dr. Cross began standard oxygen therapy, a treatment that would be insufficient for the patient's condition. The woman's oxygen saturation continued to drop. Her breathing became more desperate. Her skin took on a grayish pallor. Meanwhile, other patients were arriving in waves. The decontamination area was backed up, creating a bottleneck that slowed the treatment process. The hospital's disaster response protocols, designed for more conventional emergencies, were proven inadequate for the unique challenges of this chemical exposure incident. Dr. Webb was running between departments, trying to coordinate the response. But his lack of hands-on emergency experience was becoming apparent. He was relying on theoretical knowledge rather than practical expertise, and his decisions were creating confusion rather than clarity. Dr. Bradley was struggling with the psychological aspects of the crisis. Many of the patients were experiencing panic attacks triggered by their inability to breathe properly. But his standard psychiatric interventions were proven ineffective in the chaotic environment of the emergency department. Sarah remained in her assigned position, treating the routine cases that continued to arrive despite the crisis. But she was also watching the disaster response unfold, seeing the mistakes being made, identifying the areas where her expertise could make a difference. At 4:30 a.m., the situation began to deteriorate rapidly. The patient that Dr. Cross had triaged as moderate priority went into respiratory arrest. Despite attempts at resuscitation, she died at 4:47 a.m., the first casualty of the hospital's response to the chemical plant explosion. The death sent shockwaves through the emergency department. Dr. Cross was visibly shaken, second-guessing her decisions. Dr. Webb called for an immediate review of triage protocols. Dr. Reynolds arrived back at the hospital, demanding explanations for how a moderate priority patient had died. But the crisis was far from over. More patients were arriving, and the hospital's response was becoming increasingly chaotic. The physicians who had been assigned to lead the response were struggling with the complexity of the situation. They had theoretical knowledge, but they lacked the practical experience needed to handle this type of emergency effectively. Sarah continued to work quietly in her corner of the emergency department, treating the cases that others considered routine. But she was also preparing for the moment when her expertise would be needed. She knew that the current response was failing, and she knew that eventually, someone would have to step forward with the knowledge and skills needed to save lives. That moment was approaching faster than anyone realized. The hospital's disaster response protocols were breaking down under the pressure of the crisis. The physicians who had been put in charge were discovering that their preparations had been inadequate for the reality of the situation. And in the midst of the chaos, Sarah Mitchell, the doctor who had been dismissed as just lucky, was about to prove that luck had nothing to do with being truly prepared. At 5:23 a.m., everything changed. Sarah was examining a homeless man who had come in with chest pains when she heard Dr. Cross's voice crack over the intercom system. "Code Blue, triage area. Code Blue, triage area." The announcement was followed by the sound of running footsteps and the urgent beeping of multiple monitors. Sarah glanced at her patient, whose vital signs were stable and whose symptoms appeared to be related to anxiety rather than cardiac issues. "I'll be right back," she told him, then moved quickly toward the triage area where a crowd of medical staff had gathered around a stretcher. The patient was a middle-aged man, one of the chemical plant workers who had been closer to the explosion than most. His face was covered with an oxygen mask, but Sarah could see the telltale signs of severe chlorine gas exposure: blistered skin around his eyes and mouth, labored breathing that indicated pulmonary edema, and a grayish pallor that suggested his body was shutting down. Dr. Cross was standing over him, her hands shaking as she tried to insert in 4-line. "His blood pressure is dropping," she said, her voice tight with panic. "Oxygen saturation is at 78% and falling. I've tried everything in the protocol, but nothing's working." Dr. Webb pushed through the crowd, his face flushed with stress. "What's his status?" "Severe respiratory distress. Possible cardiac involvement," Dr. Cross replied, her voice breaking slightly. "I don't know what else to do. The standard treatments aren't working." Sarah stepped forward, her voice calm and steady. "He needs bronchial lavage and positive pressure ventilation. The chlorine has caused severe chemical burns to his respiratory tract. Standard oxygen therapy won't be enough." Dr. Webb looked at her with irritation. "Dr. Mitchell, please return to your assigned area. Dr. Cross has this under control." "With respect, Dr. Webb, she doesn't," Sarah said firmly. "This patient is going to die if we don't act in the next few minutes. I've seen this exact presentation 17 times in the past 5 years. I know how to treat it." Dr. Cross looked up from the patient, her eyes wide with desperation. 17 times? How is that possible? Industrial accidents, Sarah replied. Simply, chemical exposure cases come in at night when supervisors aren't around to prevent workers from taking risks. I've treated more chlorine gas victims than anyone in this hospital. The patient's oxygen saturation dropped to 72%. His breathing became increasingly labored, and his skin took on a blue tinge. The monitor alarms were creating a cacophony of urgent warnings. Dr. Webb hesitated, his administrative instincts warring with the reality of the situation. Dr. Mitchell, you're not authorized to. He's dying, Sarah interrupted, her voice cutting through the noise. In about 90 seconds, he's going to go into respiratory arrest. After that, we'll lose him. Do you want to explain to his family that he died because of the hospital hierarchy? Dr. Cross stepped back from the patient, her hands trembling. I don't know what to do, she admitted. Nothing I learned in the protocols covers this. Sarah looked around the room at the faces of her colleagues. She saw fear, confusion, and desperation. The hospital's disaster response was failing, and everyone knew it. The physicians who had been put in charge were discovering that their theoretical knowledge was inadequate for the reality of the crisis. Move, Sarah said quietly, stepping toward the patient. This time, no one stopped her. She worked with the fluid efficiency of someone who had done this many times before. First, she adjusted the ventilator settings to provide positive pressure ventilation that would force oxygen into the patient's damaged lungs. Then she prepared a bronchial lavage solution that would help clear the chemical residue from his respiratory tract. I need 500 milliliters of normal saline, warm to body temperature, she instructed the nurse. And get me a fiber optic bronchoscope. We need to visualize the damage and clear the airways. As she worked, Sarah explained what she was doing. Chlorine gas doesn't just affect the lungs, she said, her hands moving with practiced precision. It creates a chemical burn that damages the entire respiratory tract. Standard oxygen therapy actually makes it worse by forcing more gas into damaged tissue. We need to clear the airways first, then provide mechanical ventilation. The bronchoscope revealed severe chemical burns throughout the patient's respiratory tract. Sarah used the lavage solution to gently clear the damaged tissue and chemical residue, working with the careful precision of someone who had perfected this technique through years of practice. Heart rate is stabilizing, the nurse reported. Blood pressure is coming up. Sarah adjusted the ventilator settings again, fine-tuning the pressure and oxygen concentration based on the patient's specific needs. He's going to need continuous monitoring for the next 48 hours, she said. Chlorine gas exposure can cause delayed pulmonary edema. We need to watch for signs of secondary complications. Within 15 minutes, the patient's oxygen saturation had risen to 94%. His breathing, though still assisted by the ventilator, was no longer labored. His skin color had improved from gray to pink. The monitor alarms had stopped, replaced by the steady beeping of stable vital signs. The room was silent except for the sound of the ventilator and the patient's improved breathing. Dr. Cross stared at Sarah in amazement. How did you know to do that? Experience, Sarah replied simply. I've been preparing for this exact scenario for years. Dr. Webb cleared his throat, his expression a mixture of embarrassment and grudging respect. Dr. Mitchell, perhaps you should take a more active role in the response. But Sarah was already moving toward the next patient. The crisis was far from over, and she could see that the hospital's response was failing on multiple levels. The triage system was overwhelmed, the treatment protocols were inadequate, and the physicians in charge were struggling with conditions they had never encountered before. Over the next hour, Sarah moved through the emergency department like a force of nature. She didn't ask for permission or wait for assignments. She simply went where she was needed and did what needed to be done. In the decontamination area, She redesigned the patient flow system to reduce bottlenecks and prevent cross-contamination. She had studied mass casualty decontamination procedures extensively and had identified the flaws in the hospital's current setup within minutes of observing it. "The current system is causing delays and putting patients at risk," she explained to the charge nurse. "We need to create separate lanes for ambulatory and non-ambulatory patients, and we need to process them in order of severity, not order of arrival." The nurse, overwhelmed by the chaos, was grateful for clear direction. "What do you need me to do?" Sarah quickly outlined a new system that would double the throughput while maintaining proper decontamination protocols. Within 30 minutes, the backlog of patients waiting for decontamination had been cleared, and the system was running smoothly. In the triage area, she worked with the nursing staff to implement a more sophisticated assessment system. The standard triage protocols were designed for conventional injuries and illnesses, not for the complex combination of trauma and chemical exposure they were seeing. "Look for these specific signs," Sarah instructed, showing them how to identify the subtle indicators of severe chemical exposure. Slight discoloration around the mouth and nose, changes in breathing pattern, skin temperature variations. These patients may look stable initially, but they can deteriorate rapidly. She demonstrated the assessment techniques she had developed through years of treating chemical exposure cases. The nurses learned quickly, and soon they were identifying high-risk patients that the standard protocols would have missed. In the treatment areas, Sarah moved from patient to patient, providing specialized care that no one else in the hospital was qualified to give. She treated chemical burns with techniques she had learned from treating industrial accident victims. She managed complex respiratory cases using protocols she had developed through years of trial and error. She coordinated care for patients with multiple injuries, using systems she had perfected during countless night shifts. Dr. Bradley, who had been struggling with the psychological aspects of the crisis, watched in amazement as Sarah handled panic-stricken patients with calm authority. "How do you get them to trust you so quickly?" he asked. "Experience," Sarah replied, helping a frightened child who had been separated from her parents during the evacuation. "I've been treating scared, confused patients for years." You learn to project confidence even when everything is falling apart. As the morning progressed, the hospital's disaster response began to improve dramatically. The changes Sarah had implemented were cascading throughout the system, creating efficiency and effectiveness where there had been chaos and confusion. But the most remarkable transformation was in Sarah herself. For years, she had been relegated to the background, dismissed as lucky or naturally gifted. Now finally she was being seen for what she truly was, an expert who had spent decades preparing for exactly this type of crisis. Dr. Reynolds arrived at 7:30 a.m. to assess the situation. She expected to find chaos and confusion, but instead found a well-organized response that was handling the crisis with remarkable efficiency. She sought out Dr. Webb for an explanation. "How did you turn this around so quickly?" she asked. 3 hours ago, this was a disaster." Dr. Webb looked uncomfortable. "Dr. Mitchell took charge," he admitted. "She seems to have extensive experience with this type of situation." Dr. Reynolds found Sarah in the intensive care unit, monitoring the patients who had been most severely affected by the chemical exposure. She was checking ventilator settings, reviewing lab results, and coordinating with the nursing staff with the easy confidence of someone completely in her element. "Dr. Mitchell," Reynolds said, approaching cautiously, "I understand you've been instrumental in managing this crisis." Sarah looked up from the patient chart she was reviewing. "I've been doing what needed to be done." "Where did you learn to handle chemical exposure cases like this?" "Night shifts," Sarah replied simply. "Industrial accidents happen at night. Chemical spills happen at night. The worst cases always come in when the administrators are at home and the specialists are asleep. I've been treating these patients for years." Dr. Reynolds was quiet for a moment, processing this information. "Why didn't anyone know about your expertise?" Sarah met her gaze steadily. "Because no one asked. Because night shift work is considered routine. Because my experience didn't fit the hospital's idea of what expertise looks like." The silence stretched between them, heavy with implications. Dr. Reynolds was beginning to understand that the hospital had been overlooking a tremendous resource, that their assumptions about night shift work and the doctors who did it had been fundamentally flawed. "Dr. Mitchell," she said finally, "I think we need to have a longer conversation about your role in this hospital." But Sarah was already turning back to her patients. The crisis was still ongoing, and there was work to be done. The recognition and respect she had sought for years was finally coming, but it felt secondary to the satisfaction of doing what she had been preparing for her entire career. For the first time in years, Sarah Mitchell was exactly where she belonged, doing exactly what she was meant to do. And everyone around her was finally beginning to understand that her success had never been about luck at all. By 9:15 a.m., the emergency department at St. Mary's Hospital had transformed from a scene of chaos into a model of efficient crisis management. The last of the critical patients from the chemical plant explosion had been stabilized and transferred to appropriate units. The decontamination area had processed over 200 people without a single case of cross-contamination. The mortality rate, which had started tragically with the loss of the first patient, had dropped to 0 for the remainder of the incident. Dr. Patricia Reynolds stood in the hospital's command center, reviewing the statistics that were streaming in from various departments. The numbers told a remarkable story of recovery and success, but they didn't fully capture the dramatic turnaround that had occurred over the past 4 hours. At 5:30 a.m., the hospital had been on the verge of declaring a disaster beyond their capabilities. The initial response protocols had failed, key personnel were overwhelmed, and patients were dying from treatable conditions. Now, just 4 hours later, they were being held up as a model response by the State Emergency Management Agency. The transformation had begun the moment Sarah Mitchell took control of the situation. But the full scope of her impact was only becoming clear as the crisis wound down, and the various department heads began reporting their results. Dr. Marcus Chun, the night shift supervisor, was the first to document what had happened. He had watched Sarah work throughout the crisis, and he understood better than anyone how her expertise had saved the hospital's response from complete failure. "She didn't just treat patients," Chun explained to Dr. Reynolds during a hastily arranged debriefing session. "She redesigned our entire approach. The decontamination protocols she implemented were more sophisticated than anything in our disaster manual. The triage system she created identified high-risk patients that our standard protocols would have missed. She essentially took 20 years of specialized experience and compressed it into a 4-hour masterclass for our entire staff." Dr. Jennifer Cross, who had been visibly shaken by her initial failures, was more candid about Sarah's role than anyone had expected. "I've been preparing for mass casualty events for months," she admitted to the debriefing team. "I studied the protocols, attended the training sessions, passed all the certification exams. But when it actually happened, I realized that all of my preparation was theoretical. Dr. Mitchell has been living this for years. She knew things that aren't in any textbook, techniques that aren't in any protocol." The nursing staff was equally vocal in their praise. Rebecca Martinez, the night shift respiratory therapist, had worked closely with Sarah throughout the crisis. "She taught us more about chemical exposure treatment in one morning than we learned in all of our training combined," Martinez reported. "But more than that, she showed us how to think about these cases differently. She helped us understand the patterns and warning signs that we need to watch for." The statistics themselves were compelling evidence of Sarah's impact. Before her intervention, the hospital had lost 1 patient and had 3 others in critical condition with declining vital signs. After she took charge, all subsequent patients were stabilized successfully. The average treatment time had decreased by 40%. The accuracy of initial diagnoses had improved by 60%. Patient satisfaction scores, even in the midst of a disaster, had reached unprecedented levels. But perhaps most importantly, Sarah had managed to coordinate the treatment of over 70 patients with complex chemical exposure and trauma injuries, using resources that had initially seemed inadequate for half that number. She had done this not by working harder, but by working smarter, applying years of accumulated knowledge and experience to optimize every aspect of the response. Dr. Harrison Webb found himself in the uncomfortable position of having to explain to the hospital board why he had initially sidelined the doctor who ultimately saved their response. During an emergency board meeting convened at 10 a.m., he struggled to articulate his decision-making process. Dr. Mitchell has always been competent, Webb said carefully, but she works night shifts, and her experience seemed to be primarily with routine cases. We couldn't have predicted that she had this level of specialized expertise. Board member Elizabeth Hartman, herself a former emergency physician, was not satisfied with this explanation. Dr. Webb, according to these reports, Dr. Mitchell has treated more chemical exposure cases than any other physician in this hospital. How is it possible that you didn't know this? Webb's discomfort was palpable. Our reporting systems don't track that level of detail for night shift cases. Day shift incidents are more thoroughly documented because they occur during administrative hours. So you're telling me, Hartman continued, that we have a physician with 20 years of specialized experience in exactly the type of emergency we just faced, and our system was so poorly designed that we didn't even know about her expertise? The question hung in the air, highlighting the fundamental flaws in the hospital's approach to recognizing and utilizing its human resources. The board members exchanged glances, clearly recognizing that this was a systemic problem that extended far beyond a single crisis response. Meanwhile, in the ICU, Sarah was conducting rounds on the patients who had been most severely affected by the chemical exposure. The plant supervisor, James McKenna, had been unconscious when he arrived, but was now awake and breathing on his own. The young mother, Lisa Chen, who had been caught in the gas cloud while evacuating her apartment, was sitting up in bed and asking about her children. Each patient represented a success story that had seemed impossible just hours earlier. But for Sarah, the satisfaction came not from the recognition she was finally receiving, but from the knowledge that her years of preparation had made a tangible difference in people's lives. Dr. Amanda Foster, the resident who had rotated through night shifts with Sarah, arrived at the hospital at 11 a.m. for her scheduled day shift. She was stunned to learn about the crisis and Sarah's role in managing it. Foster sought out Sarah in the ICU, her expression a mixture of amazement and embarrassment. "Dr. Mitchell," Foster said, approaching carefully, "I just heard about what happened. I had no idea you had this kind of experience." Sarah looked up from the chart she was reviewing. "You worked with me for 2 months, Amanda. You saw me treat chemical exposure cases, trauma patients, complex medical emergencies. What did you think was happening?" Foster was quiet for a moment, processing the implications of Sarah's question. "I guess I thought you were just naturally good at it. I didn't realize you were drawing on such extensive specialized experience." "That's the problem," Sarah replied gently. "Everyone assumed that quick, accurate diagnoses meant natural talent rather than learned expertise. Everyone thought that efficient treatment meant good instincts rather than systematic preparation. It was easier to believe I was lucky then, to acknowledge that I had been preparing for this for 20 years. The conversation was interrupted by Dr. Reynolds, who had been looking for Sarah throughout the hospital. "Dr. Mitchell, I need to speak with you privately." They walked to a quiet conference room adjacent to the ICU. Reynolds closed the door and took a seat across from Sarah, her expression serious but respectful. "I owe you an apology," Reynolds began. "This hospital owes you an apology. We've been blind to your capabilities, and our blindness nearly cost lives today." Sarah remained silent, waiting for Reynolds to continue. "I've spent the morning reviewing your case history, your patient outcomes, your innovations in treatment protocols. Your record is extraordinary, Dr. Mitchell. By any reasonable measure, you should be leading this department, not working night shifts. What are you proposing?" Sarah asked. "I want to offer you the position of Director of Emergency Medicine," Reynolds said. "Dr. Webb has agreed to step back into a more administrative role. This crisis has made it clear that we need someone with your level of practical expertise leading our emergency response." Sarah considered the offer carefully. It was everything she had worked toward for years: recognition, authority, the opportunity to implement her knowledge on a larger scale. But it was also a fundamental change in her approach to medicine, a shift from direct patient care to administrative responsibility. "I appreciate the offer," Sarah said finally, "but I need some time to think about it. This crisis isn't over yet. We still have patients to monitor, protocols to refine, lessons to document. Let me finish what I started here, and then we can discuss the future." Reynolds nodded, impressed by Sarah's focus on patient care, even in the midst of career-changing opportunities. "Of course. Take all the time you need." As Reynolds left, Sarah returned to her patients. The recognition and opportunities would wait. The immediate needs of the people under her care would not. But as she worked, Sarah was aware that something fundamental had changed. The colleagues who had dismissed her as lucky now sought her advice. The administrators who had overlooked her expertise now recognized her value. The hospital that had relegated her to night shifts now understood what they had been missing. The crisis at the chemical plant had ended. The gas cloud had dissipated. The structural damage had been secured, and the evacuation orders had been lifted. But the crisis at St. Mary's Hospital had revealed something more important than anyone had expected: that true expertise doesn't always look the way people expect it to look, and that the most valuable resources are sometimes hidden in plain sight. Sarah Mitchell had spent 20 years preparing for this moment, not just as a doctor, but as someone who understood that real preparedness means being ready for the unexpected, able to adapt to any situation, and capable of performing at the highest level when it matters most. She had never been lucky. She had been ready. And now, finally, everyone else knew it too. 3 weeks after the chemical plant explosion, Sarah Mitchell walked through the halls of St. Mary's Hospital at 6 p.m., beginning what had become a very different kind of night shift. The familiar weight of her stethoscope around her neck felt the same, but everything else had changed in ways both subtle and profound. The transformation hadn't happened overnight. It had unfolded gradually, like a photograph developing in slow motion, revealing details that had always been there, but had never been properly seen. The first sign had been something as simple as eye contact. Colleagues who had previously looked through her now met her gaze directly, nodding with genuine respect rather than polite acknowledgement. Dr. Jennifer Cross had been among the first to approach Sarah with a request that would have been unthinkable just a month earlier. Cross had been struggling with a patient who had presented with unusual respiratory symptoms, and after consulting several specialists without success, she had swallowed her pride and sought Sarah's opinion. "I know this might seem strange," Cross had said, her voice carrying none of its usual confidence, "but I have a patient with symptoms that remind me of some of the chemical exposure cases from the incident. I was wondering if you could take a look." The patient, it turned out, was a janitor who had been exposed to an unusual combination of cleaning chemicals in a poorly ventilated storage room. Sarah had recognized the presentation immediately. It was identical to a case she had treated 4 years earlier during a night shift. The diagnosis and treatment that had puzzled the day shift specialists was routine. For someone who had spent years treating occupational exposure cases that typically arrived after hours, word of Sarah's accurate diagnosis spread quickly through the hospital's informal communication network. Within days, she was receiving consultation requests from departments that had never acknowledged her existence. The infectious disease team wanted her input on unusual presentations that might be related to environmental exposures. The toxicology unit sought her advice on treatment protocols for industrial accident victims. The emergency medicine residency program asked her to develop a curriculum on night shift emergency management, but perhaps the most significant change was in how her colleagues discussed her work. The casual dismissals and offhand comments about luck had been replaced by careful attention to her methods and reasoning. During morning rounds, attending physicians would reference Dr. Mitchell's approach when discussing difficult cases. Residents would mention specific techniques they had learned from her. Nurses would share stories about innovations she had implemented that had improved patient outcomes. Dr. Marcus Chun, who had always respected Sarah's abilities, found himself in the unique position of watching his colleagues' reputation transform in real time. "It's fascinating," he confided to Dr. Reynolds during a department meeting. "Her skills haven't changed at all. She's exactly the same doctor she was 6 months ago. But now everyone can see what was always there." The medical students who rotated through the emergency department had begun requesting assignments to Sarah's night shifts, viewing them as intensive learning experiences rather than routine rotations. Word had spread through the academic network that Dr. Sarah Mitchell was providing unparalleled training in emergency medicine, particularly in areas that traditional curricula rarely covered. One student, David Park, a third year from Johns Hopkins, had specifically arranged to spend a month working with Sarah after hearing about her reputation from Dr. Kim, the trauma surgeon who had inspired Sarah's preparation philosophy years earlier. Park's expectations had been high, but the reality exceeded them. "She doesn't just treat patients," Park explained to his classmates during a video call back to Baltimore. "She teaches you to see patterns that aren't in textbooks, to recognize presentations that aren't in standard diagnostic criteria. Last night, she diagnosed a rare form of pneumonia by noticing the way a patient was positioning his shoulders. It took the lab 12 hours to confirm what she knew in 5 minutes. The recognition extended beyond St. Mary's Hospital." Dr. Elizabeth Hartwell, the emergency medicine chief who had unknowingly inspired Sarah's approach during her residency, had learned about the chemical plant incident through professional networks. She had reached out to Sarah directly, expressing both admiration for her work and curiosity about her training methods. "Your response to that mass casualty event has become a case study," Hartwell explained during a phone conversation. "Emergency management teams across the region are trying to understand how you achieve such remarkable outcomes with limited resources. Would you consider presenting your methods at the National Emergency Medicine Conference?" Sarah had agreed, but with a characteristically practical condition. The presentation would focus on systematic preparation rather than individual achievement, on replicable methods rather than personal success. She had spent weeks developing a comprehensive framework that other hospitals could use to identify and develop expertise within their own night shift operations. The presentation, delivered to an audience of over 500 emergency medicine professionals, had been titled "Beyond Luck: Building Expertise Through Systematic Preparation." Sarah had methodically outlined the preparation protocols she had developed, the pattern recognition techniques she had refined, and the continuous learning systems that had made her ready for the chemical plant crisis. But she had also addressed the systemic issues that had kept her expertise hidden. "The most dangerous assumption in emergency medicine," she had told the audience, "is that good outcomes indicate natural talent rather than developed skill. When we dismiss systematic preparation as luck, we miss opportunities to replicate and improve upon successful approaches." The response had been overwhelming. Hospital administrators across the country began reevaluating how they identified and utilized expertise within their organizations. Emergency medicine programs started incorporating night shift experience as a required component of residency training. Professional development initiatives began focusing on the kind of continuous learning that Sarah had exemplified. Back at St. Mary's, the institutional changes had been equally significant. Dr. Patricia Reynolds had restructured the hospital's approach to emergency preparedness, creating formal mechanisms for documenting and sharing the expertise that existed within night shift operations. The disaster response protocols had been completely rewritten, incorporating the innovations Sarah had developed during the chemical plant incident. Dr. Harrison Webb, who had initially failed to recognize Sarah's capabilities, had become an unexpected advocate for her methods. During a meeting with the hospital board, he had presented a comprehensive analysis of how the hospital's previous approach to talent recognition had created blind spots that nearly proved catastrophic. We were evaluating our physicians based on visibility rather than competence, on networking rather than patient outcomes, Webb had admitted. Dr. Mitchell's expertise was invisible to us not because it didn't exist, but because we weren't looking in the right places or measuring the right things. The board had approved a comprehensive overhaul of the hospital's human resource evaluation systems, creating new metrics for identifying expertise and new pathways for recognizing achievement. The changes went far beyond Sarah's individual case, addressing systemic issues that had affected numerous employees across various departments. But for Sarah herself, the most meaningful changes were the quieter ones. The night shift staff, who had always respected her abilities, now felt validated in their own expertise. Rebecca Martinez had been promoted to a newly created position as night shift respiratory care coordinator. Tom, the radiology technician, had been asked to develop training protocols for after-hours imaging procedures. Marcus had finally received the promotion he had been passed over for repeatedly. The culture of the night shift had evolved from one of resigned acceptance to one of recognized excellence. The staff members who had been dismissed as handling routine cases now understood that their work was valued and their expertise was acknowledged. The innovations and improvements they had developed in isolation were now being documented, shared throughout the hospital system. Sarah had ultimately accepted the position of Director of Emergency Medicine, but she had negotiated an arrangement that allowed her to continue working night shifts 2 days per week. My expertise was developed through direct patient care, she had explained to Dr. Reynolds. If I lose touch with that foundation, I'll lose the very thing that makes me effective. The arrangement had proven beneficial for everyone involved. Sarah's administrative leadership had transformed the emergency department's operations, while her continued clinical work ensured that she remained connected to the practical realities of patient care. The residents and medical students who worked with her during those night shifts received training that was unavailable anywhere else in the country. 6 months after the chemical plant explosion, Sarah received a letter from James McKenna, the plant supervisor who had been one of the most critically injured patients. He had made a complete recovery and had returned to work, but he had also become an advocate for industrial safety improvements that would prevent similar incidents. Dr. Mitchell, he had written, I wanted you to know that my family and I understand that your quick thinking and expertise saved my life. But I also wanted to tell you that your work has had impacts beyond that single day. The safety protocols that have been implemented as a result of the incident investigation will protect countless workers in the future. Your preparation didn't just save lives that day, it's continuing to save lives every day. The letter had arrived on a quiet Tuesday evening during one of Sarah's night shifts. She had read it during a brief break between patients, sitting in the same break room where she had once eaten lunch alone while colleagues dismissed her as lucky. But now, as she folded the letter and returned to her rounds, she understood that the real victory wasn't in the recognition she had finally received. The real victory was in the knowledge that 20 years of quiet preparation had proven its worth when it mattered most. The real victory was in the understanding that expertise built through systematic effort was more reliable than talent, more valuable than luck, and more powerful than institutional recognition. Sarah Mitchell had never been lucky. She had been ready. And in being ready, she had not only saved lives, she had changed the way an entire profession thought about preparation, expertise, and the quiet strength that comes from knowing you're prepared for whatever challenges lie ahead. As she walked through the halls of St. Mary's Hospital that evening, Sarah carried with her the satisfaction of work well done and the quiet confidence that comes from knowing that success isn't about being in the right place at the right time. It's about being so thoroughly prepared that you're ready for any place, any time, any challenge that comes your way. The legacy Sarah had built extended far beyond the walls of St. Mary's Hospital. Her story had become part of medical school curricula, taught as an example of how systematic preparation could triumph over institutional blindness. Emergency medicine textbooks now included case studies based on her chemical plant response, and her preparation protocols had been adopted by hospitals across 3 states. But perhaps most importantly, Sarah had inspired a new generation of medical professionals to think differently about expertise and preparation. Young doctors no longer assumed that quick diagnoses meant natural talent. Nurses understood that pattern recognition was a skill that could be developed through dedicated practice. Hospital administrators learned to look beyond traditional measures of achievement to identify the quiet experts working within their organizations. The night shift at St. Mary's had become a destination rather than a consolation prize. Medical residents competed for positions there, knowing they would receive training that was unavailable during day shifts. The department that had once been seen as a place for doctors who couldn't make it was now recognized as an elite training ground for emergency medicine excellence. On this particular evening, as Sarah reviewed the patient charts from the day's cases, she reflected on how profoundly her approach to medicine had influenced others. The systematic preparation methods she had developed in isolation were now being taught in medical schools. The pattern recognition techniques she had refined through years of night shift experience were being studied by researchers. The continuous learning philosophy that had driven her career was being adopted by physicians around the world. Yet Sarah understood that her greatest achievement wasn't in the recognition she had received or the changes she had inspired. It was in the knowledge that when the moment of ultimate testing had arrived, she had been ready. 20 years of preparation had culminated in a single day, when her expertise had meant the difference between life and death for dozens of people. That readiness, that moment of proving that systematic preparation could overcome any challenge, was the true measure of her success. The story of Sarah Mitchell serves as a powerful reminder that excellence isn't about luck, timing, or natural ability. It's about the quiet determination to prepare for challenges that may never come, to develop skills that others overlook, and to maintain standards of excellence even when no one is watching. In a world that often celebrates flashy achievements and overnight success, Sarah's journey demonstrates the enduring power of methodical preparation, continuous learning, and unwavering dedication to one's craft. Years later, when medical historians would analyze the transformation of emergency medicine in the early 21st century, they would point to the chemical plant incident at St. Mary's Hospital as a pivotal moment. Not because of the technical innovations or the statistical improvements, but because it revealed how institutions could overlook extraordinary expertise simply by failing to look in the right places. Dr. Amanda Foster, who had rotated through Sarah's night shifts years earlier, eventually became chief of emergency medicine at Massachusetts General Hospital. During her installation ceremony, she spoke about the lesson that had shaped her entire approach to leadership. I learned that the most dangerous phrase in medicine is, "You're just lucky." When we dismiss excellence as luck, we stop asking the questions that could help us replicate that excellence in others. The ripple effects of Sarah's story continued to spread through unexpected channels. Hospital security guards, inspired by her example, began documenting patterns they observed during their rounds, leading to improved safety protocols. Maintenance. Staff started tracking equipment failures and developing predictive maintenance schedules that prevented critical system failures. Cleaning crews identified infection control improvements that reduced hospital-acquired infections by 15%. Sarah's philosophy of systematic preparation had shown everyone in the hospital that expertise could be developed in any role, at any level, by anyone willing to observe carefully, learn continuously, and prepare methodically. The culture of St. Mary's evolved from one that celebrated individual heroics to one that valued collective preparation and shared learning. The emergency medicine conference where Sarah first presented her methods had evolved into an annual symposium on hidden expertise in healthcare. Hospitals from around the world sent representatives to learn how to identify and develop the quiet experts working within their own organizations. The symposium's most popular session was always the night shift advantage, where Sarah and other night shift physicians shared the unique insights they had gained from working outside traditional hierarchies. International medical organizations began incorporating Sarah's story into their leadership development programs. The World Health Organization included her case study in their guidelines for emergency preparedness in developing nations. Military medical units adapted her training protocols for battlefield conditions. Disaster relief organizations used her systematic approach to prepare medical teams for humanitarian crises. But Sarah's influence extended beyond medicine. Business schools began teaching her story as an example of how organizations could overlook their most valuable assets. Leadership. Consultants used her experience to demonstrate the importance of looking beyond traditional performance metrics. Human resources professionals learned to recognize the difference between visible achievement and substantive expertise. The apartment where Sarah had spent 20 years preparing for her moment of testing became a symbol within the medical community. Young doctors would visit, seeing the mannequin, the reference materials, and the systematic approach that had created such extraordinary expertise. Many left inspired to create their own preparation protocols, their own systems for continuous learning, their own paths to excellence that didn't depend on institutional recognition. Sarah Mitchell had proven that when preparation meets opportunity, the result isn't luck, it's inevitability. Her story became a testament to the idea that true expertise is built quietly, tested under pressure, and proven when it matters most. In a profession where lives hang in the balance, she had shown that being ready isn't just a professional obligation, it's a moral imperative that can change everything when the moment arrives. Up next, you've got two more standout stories right on your screen. If this one hits the mark, you won't want to pass these up. Just click and check them out. And don't forget to subscribe and turn on the notification bell so you don't miss any upload from us.